Hello students, my name is Gandharva Hemant Pednekar, Research Associate, School of Development Studies, Tata Institute of Social Sciences, Mumbai. Today I will be discussing about the module on National Health Programs and Schemes in India, Part A. The learning objectives of this module are to know about various national health programs and schemes in India. Health programs started on the basis of community requirements and also agenda of the government. The following are health-related programs started by the Government of India. Malaria. Malaria was killing 10 lakh people every year at the time of independence. National Malaria Eradication Program was started in 1958. It is the biggest health program against a single disease. As a result of this, the number of cases due to malaria declined. The disease is still existing in the country and effective efforts are still required to eradicate this disease. Malaria is an ancient disease as old as human civilization. Malaria is probably one of the oldest diseases known to mankind. Man and malaria seem to have evolved together, and it has been known to mankind for last millennia. It was always part of the ups and downs of nations, of wars, and of upheavals. Mention of this disease can be found in the ancient Chinese, Indian, and Egyptian manuscripts. The disease supposedly had its origin in the jungles of Africa, where it is still very much rampant. To overcome this situation, modified plan of operation was introduced in 1977. The reasons of resurgence in 1995 are as unplanned growth of urban area, absence of bylaws in municipal council or corporations, rapid industrialization, labor aggregation at project site, population movement across the border, inadequate health service in tribal area, suspected insecticide and drug resistance. World Bank assisted enhanced malaria control program. Insecticides, material and equipment, petrol, oil, etc., telephone bills, payment of spraying staff and honorarium to malaria link volunteers, officers staff training, health education. The milestones of the program are as under: 1953 National Malaria Control Program, 1958 National Malaria Eradication Program, 1977 Modified Plan of Operation, 1979 Multipurpose Worker Scheme, 1995 Implementation of Malaria Action Plan, 1997 Launching of World Bank assisted enhanced malaria control project in tribal districts of the state. 2000 National Anti-Malaria Program. 2004 National Vector-Borne Disease Control Program. Now we'll talk about National Framework for Malaria Elimination 2016 to 2030. The National Framework for Malaria Elimination 2016 to 2030 has been developed together with partners and other key stakeholders. The vision is to eliminate malaria nationally and contribute to improved health, quality of life, and alleviation of poverty. The NFME has clearly defined goals, objectives, strategies, targets, and timelines, and will be serve as a roadmap for advocating and planning malaria elimination throughout the country in a phased manner. Necessary guidance is expressed for rolling out the strategies and related interventions in each state or union territory as per respective epidemiological situation. The objectives are to 1. Eliminate malaria from Category 1 and Category 2 states union territories with low and moderate transmission of malaria by 2022. Second, reduce the incidence of malaria to less than 1 case per 1000 population per year in all states and union territories and their districts and achieve malaria elimination in 31 states or union territories by 2024. Third, interrupt indigenous transmission of malaria in all states and union territories category 3 by 2027. And fourth, prevent re-establishment of local transmission of malaria in areas where it has been eliminated and maintain malaria-free status nationally by 2030. The milestones and targets are set for 2016, 2020, 2022, 2024, 2027 and 2030. It is expected that by 2030, the entire country will have sustained zero indigenous cases and deaths due to malaria for 3 years and initiated the process for WHO certification of malaria elimination. By the end of 2016, all states and union territories are expected to include malaria elimination in their broader health policies and planning framework. And by end of 2020, 15 states and union territories under category 1, the elimination phase, are expected to interrupt transmission of malaria and achieve zero indigenous cases and deaths due to malaria. It is also envisaged that in states with relatively good capacity and health infrastructure, namely Gujarat, Karnataka and Maharashtra, accelerated efforts may usher in malaria elimination sooner. The NFME 2016-2030 defines such key strategic approaches as program phasing consideration, the varying malaria endemicity in the country, classification of states union territories based on API as primary criteria, category 0 prevention of re-establishment phase, category 1 elimination phase, category 2 pre-elimination phase, category 3 intensified control phase. Districts as the unit of planning and implementation focus on high endemic areas and a special strategy for PYVAX elimination. An enabling environment and necessary resources are critical to achieving the objective of malaria elimination. Smallpox. Smallpox was a deadly disease. India had eradicated this disease from the country since April 1977. It was a big achievement of healthcare program. If we look at the smallpox eradication in India in the period 1972 to 1977, the chronology of the eradication campaign is as follows. 1972 to 1973 intensive campaign in endemic Indian states. October 1972, the Indian states are divided into two categories, endemic and non-endemic. The endemic states receive the highest priority and majority of the available resources. State surveillance teams are created in urgent areas. November 1972, the final phase of the global smallpox eradication program is announced. In India, the target is to reduce the incidence of smallpox to zero during the course of the next two smallpox seasons. June to December 1973. A special intensified campaign is launched in June. The first phase takes place in July and August in the urban areas. The second phase occurs from September to December. The country-wide second phase has a special emphasis on four major endemic states: Bihar, Madhya Pradesh, Uttar Pradesh, and West Bengal. 1974. Further intensification and expansion of the program. January 1974. The Director General of the World Health Organization agrees to make available $9 lakh to augment existing resources. More WHO epidemiologists are deployed in India. During 1974, at any given time, approximately 100 national and international epidemiologists are working in the field, primarily in the heavily affected areas. May 1974. The number of smallpox outbreaks peak with 11,000 new cases reported in single week. January 1975, launch of Operation Smallpox Target Zero. Containment of all suspected smallpox cases and chickenpox deaths is undertaken pending definitive diagnosis. 7 April 1975. The theme of World Health Day, Smallpox Point of No Return, coincides with an all-India search operation that lasts until 14th April 1975. May 24, 1975. The last known Indian smallpox patient, a 30-year-old female, is identified. July 5th, 1975. An independent assessment report proclaims that there is no evidence of smallpox after 5th of July 1975. April 1977. 2 years search and active surveillance activities confirm that India is free of smallpox. December 1979. Smallpox is officially eradicated from the planet. Now we'll have a look at tuberculosis. It is commonly known as TB. To control TB, National TB Control Program was started in 1955. A large number of TB hospitals have been opened across the country. Revised National Tuberculosis Control Program was launched from April 1977. District TB centers are functioning in 446 districts of the country. RNTCP, Government of India TB Treatment and Care, the largest scale implementation of the Indian government's revised National TB Control Program or RNTCP, sometimes also known as RNTCP-1, was started in 1997. The RNTCP was then expanded across India until the entire nation was covered by the RNTCP in March 2006. At this time, the RNTCP also became known as RNTCP-2. RNTCP-2 was designed to consolidate the gains achieved in RNTCP-1 and to initiate services to address TB, HIV, MDR-TB and to extend RNTCP to the private sector. RNTCP uses the World Health Organization recommended directly observed treatment short course or DOTS strategy and reaches over 1 billion people in 632 districts or reporting units. With the RNTCP, both diagnosis and treatment of TB are free. There is also, at least in theory, no waiting period for patients seeking treatment and TB drug. The initial objectives of the RNTCP in India were to achieve and maintain a TB treatment success rate of at least 85% among new sputum positive NSP patients, to achieve and maintain detection of at least 70% of the estimated new sputum positive people in the community. New sputum positive patients are those people who have never received TB treatment before or who have taken TB drugs for less than a month. They have also had a positive result to a sputum test which diagnoses them as having TB1. National Strategic Plan NSP and Standards or TB Care in India. The work required by the RNTCP is set out by the Government of India in the National Strategic Plan 2012 to 2017. In addition to implementing the NSP 2012 to 2017, the Government of India had also in 2014 agreed the standards for TB care in India, which sets out the standard of TB treatment in India and TB testing and diagnosis in India that should be provided by the RNTCP in all parts of India. This has subsequently been endorsed by the Ministry of Health and Family Welfare. Among other points, This acknowledged that patients would be treated by private providers rather than simply demanding that unwilling patients should be referred to the public sector. The Government of India had also in 2014 adopted with all member states of the WHO the End TB strategy. The End TB strategy, together with these other initiatives, effectively called a major transformation of India's current approach to tackling TB. Now we'll discuss about leprosy. As Mahatma Gandhi said, leprosy work is not merely relief. It is transforming frustration of life into joy of dedication, personal ambition into selfless service. Leprosy is another communicable disease which is prevalent in the country. India has highest number of leprosy patients in the world. There were nearly 20 lakh leprosy patients in India in 1990-91. National Leprosy Control Program was started in 1955. In 1983, the program was renamed as National Leprosy Eradication Program. The program aims at eliminating leprosy from the country. The National Leprosy Eradication Program is a centrally sponsored health scheme of the Ministry of Health and Family Welfare, Government of India. The program is headed by the Deputy Director of Health Services, Leprosy, under the administrative control of the Director General Health Services, Government of India. While the NLEP strategies and plans are formulated centrally, the program is implemented by the state and union territories. The program is also supported as partners by the World Health Organization, the International Federation of Anti-Leprosy Associations, and few other non-government organizations. Leprosy is a chronic infectious disease caused by Mycobacterium leprae. It usually affects the skin and peripheral nerves, but has a wide range of clinical manifestations. The disease is characterized by long incubation period, generally 5 to 7 years, and is classified as paucibacillary and multibacillary, depending on the bacillary load. Leprosy is a leading cause of permanent physical disability. Timely diagnosis and treatment of cases before nerve damage has occurred is the most effective way of preventing disability due to leprosy. Milestones in NLEP 1955 National Leprosy Control Program NLCP launched. 1983 National Leprosy Eradication Program launched. 1983 Introduction of Multi-Drug Therapy MDT in phases. 2005 Elimination of leprosy at national level. 2012 Special Action Plan for 209 hive endemic districts in 16 states and union territories. Early detection of leprosy is key to its elimination. Kala Azar Elimination Program. Kala Azar has been a serious medical and public health problem in India since historical times. Bengal is the oldest known Kala Azar endemic area of the world. After the initial success, Kala Azar resurged in 70s. Concerned with the increasing problem of Kala Azar in the country, the Government of India launched a centrally sponsored Kala Azar control program in the endemic states in 1990-91. The Government of India provided drugs, insecticides and technical support, and state governments provided costs involved in implementation. The program was implemented through state or district malaria control offices and the primary health care system. The program brought a significant decline in Kala Azar morbidity, but could not sustain the pace of decline for long. The National Health Policy 2002 set the goal of Kala Azar elimination in India by year 2010, which was revised to 2015. Continuing focus activities with high political commitment, India signed a tripartite memorandum of understanding with Bangladesh and Nepal to achieve Kala Azar elimination from the Southeast Asia region. Elimination is defined as reducing the annual incidence of Kala Azar to less than 1 case per 10,000 population at the sub-district, that is block PHCs level in Bangladesh and India, and at district level in Nepal. Presently, all programmatic activities are being implemented through the National Vector-Borne Disease Control Program, that is NVBDCP, which is an umbrella program for prevention and control of vector-borne diseases and is subsumed under National Health Mission. Goal: to improve the health status of vulnerable groups and at-risk population living in Kala Azar endemic areas by the estimation of Kala Azar so that it no longer remains a public health problem. The target: to reduce the annual incidence of Kala Azar to less than 1 per 10,000 population at block PHC level. The objectives are to reduce the annual incidence of Kala Azar to less than 1 per 10,000 population at block PHC level by the end of 2015 by 1. Reducing Kala Azar in the vulnerable, poor and unreached populations in endemic areas. 2. Reducing case fatality rates from Kala Azar to negligible level. 3. Reducing cases of PKDL to interrupt transmission of Kala Azar and preventing the emergence of Kala Azar and HIV or TB co-infections in endemic areas. Strengthening capacity of human resources in health. Kala Azar elimination will require effective involvement of health personnel at all levels in continuum of care, right from the early identification of a suspect case to diagnosis and management, including complications. This can be achieved by orientation of human resource in health appropriate for different levels. There are multiple actors engaged in KA control program like ASHA at community level, A&M at sub-health center level, laboratory technicians and supervisory staff in the form of Kala Azar technical supervisors at primary health care center level, district VBD consultants, PHC and district medical and program officers. In addition, other stakeholders like BMGF stroke care are also made provisions for human resource support at the district and block level through district program manager and link workers at block PHC respectively. Roles and responsibilities at each level need to be defined and followed. Advocacy, communication and social mobilization for behavioral impact and intersectoral convergence. The population at risk for Kala Azar is among the poorest in the community and often poorly nourished. Access to care remains an issue in at-risk population and other underprivileged sections of communities. Inadequate utilization of health services and lack of faith in public health systems by the affected population are major barriers in achieving elimination. This can be addressed by intensive awareness campaigns with the involvement of communities and community health volunteers. Awareness about the disease, its feature, diagnostic and treatment options, prevention, existing schemes and incentives and other aspects of the disease are not widely known. Therefore, there is a need for advocacy, communication and social mobilization through all the existing methods like wall writing, hoardings, banners, pamphlets, radio jingles, etc. as per the local context. Opportunities should be explored to spread the message during weekly market or any other mass gathering like Chhat Puja, fairs, melas, etc. Display of messages, particularly during campaigns which are community based and interpersonal communication, are considered the best methods for spreading awareness. Program management. Program management is the most important operational component for success of Kala Azar elimination. It involves coordination between center and state level offices as well as effective coordination and harmonization of activities with different partners in the program. Day-to-day management of the program activities like cold chain management, drug requests, procurement and transportation of drugs, diagnostics and commodities, planning and monitoring need to be strengthened at all levels of implementation. AIDS. Acquired immune deficiency syndrome or AIDS is one of the most dangerous disease. In India, it is spreading fast. National AIDS Control Program had been launched in 1987. Up to 1991, 29 zonal blood testing centers had been established. People are being made conscious about AIDS through mass media. At national level, National AIDS Control Organization (NACO) has been established. In Orissa state, Orissa AIDS Cell (OAC) has been established by state government. OAC has started many projects including making people conscious about the evils of AIDS, identification of AIDS patients and helping people to take preventive measures and laws to shun fears from the minds of people. Non-government organizations are working to bring awareness among people living in slums, labor colonies and especially among truck drivers who are main victims of this disease. OAC is the first in the country to have HIV/AIDS task force. 3 medical colleges in the state have opened free blood testing units. Polio. Pulse Polio Program (PPP) has been launched in India to eradicate polio. People gave tremendous response to this program. To immunize the children from this disease, the anti-polio drops are given to children below the age of 5 years. Goiter Control Program. This disease is quite common in India. About 14.5 crore people are patients of this disease. To control this disease, iodized salt is provided to people and awareness among people is created through mass media to use iodized salt. Maternal and child health services. Maternal and child health services are provided to people in rural and urban area through existing health infrastructure. The services include prenatal and postnatal care, immunization, and oral rehydration therapy to fight against diarrhea. One of the important program is Universal Immunization Program. Under this program, vaccination is provided against diphtheria, tetanus, polio, tuberculosis, and measles, etc. Other national health programs. National Program for Prevention and Control of Fluorosis (NPPCF), National Tobacco Control Program (NTCP), National Program for Health Care of the Elderly (NPHCE), Mission Indradhanush. Full immunization against preventable childhood diseases is the right of every child. With a view to provide this right to every child, the Government of India launched the Universal Immunization Program in 1985, one of the largest health programs of its kind in the world. Despite being operational for over 30 years, UIP has been able to fully immunize only 65% children in the first year of their life, and the increase in coverage has stagnated in the past 5 years to an average 1% every year. To strengthen and invigorate the program and achieve full immunization coverage for all children at a rapid pace, the Government of India launched Mission Indradhanush in December 2014. Mission Indradhanush will ensure that all children under the age of 2 years and pregnant women are fully immunized with all available vaccines. The mission is strategically designed to achieving high quality routine immunization coverage while contributing to strengthening health systems that can be sustained over years to come. In the last few years, India's full immunization coverage has increased only by 1% per year. The mission has been launched to accelerate the process of immunization and achieve full immunization coverage for all children in the country. The government has identified 201 high focus districts across 28 states in the country that have the highest number of partially immunized and unimmunized children. Mission Indradhanush will target these districts through intensive efforts and special immunization drives to improve the routine immunization coverage in the country. Traditional system of medicine. The four traditional systems of medicines like Ayurveda, Siddha, Unani and homeopathy are made popular to serve humanity. Each system has a central council and an attached research council. Ayurvedic and homeopathic colleges, hospitals and dispensaries have been established in all states. These medicines are cheap. The common man can purchase these. Thank you. We'll continue this module in the second part.